Yeah, okay, to make things a little bit more complex, so this is a patient we often encounter in our daily practice, and this is a patient with non-STEMI and paroxysmal atrial fibrillation. So this is a 68-year-old woman. She's diabetic, hypertensive, obese, and hyperlipidemic, and has a history of paroxysmal atrial fibrillation. She's been treated on with ACE inhibitors, amiodarone, a statin, and she's on warfarin. She's admitted with recent onset anginal complaints. She has a positive high sensitivity troponin. Her creatinine is 1.6 milligrams per deciliter, which equals a GFR of 40 milliliters per minute. She's slightly anemic. Her hemoglobin level is 10.8 grams, and her INR is 2.4. So quite a complicated decision making. She's been pre-treated with 300 milligrams of clopidogrel loading dose in the ER, and admitted to cardiology, and she's continued on aspirin the next morning, and then taken to the cath lab for angiography through a radial approach. And this is her angiography showing 2 lesions in the LAD, significant lesions, and she's been treated with 2 drug-eluting stents of 2.5 millimeters with a total length of 46 millimeters, and it's a successful procedure. So what do we have? We have a recent statement just published, I think, two weeks ago in Circulation Cardiovascular Intervention. This is a North American perspective, an executive summary regarding the use of dual antiplatelets in patients who are undergoing coronary stenting and need Coumadin or warfarin or any other anticoagulant. And this statement specifically says that these patients, of course, are in a very high risk of bleeding. However, as such, prasugrel and ticagrelor should not be used in combination with oral anticoagulants until adequate safety data is available. Now, what about our patient? Is she in a high bleeding risk? This is the has-bled score, and our patient has at least 4 of these parameters. She is hypertensive, she is abnormal kidney function, she has a bleeding tendency, or at least she's anemic, and she is above 65 years old, so she's definitely in a high risk of bleeding. What about her stent thrombosis risk? So these are just some of the parameters that increase the patient's risk of stent thrombosis. I didn't have enough place in the slide to list them all, but I think that, as you can see, she is in high risk of bleeding. She also has 46 millimeters of drug-eluting stents in her LAD. So she definitely needs some kind of a treatment that would reduce her stent thrombosis risk. So what does this statement say about the triple antiplatelet or anticoagulant therapy? Well, I would use this algorithm as a background for our discussion, but what they suggest, of course, is evaluate the stent thrombosis risk, and at the same time evaluate the bleeding risk, and then make up your mind. How would you select both the stent type, and how would you select the therapy, the medical therapy, and for how long? So I now would ask the panel, how would you treat the patient? So that's what we did with the patient, just the last slide. We continued her on triple therapy for 1 month, then we discontinued the aspirin and kept her on clopidogrel and Coumadin for 1 year, and then discontinued clopidogrel and continued aspirin, and warfarin continues. Thank you.
Thank you, Dr.